Let's talk about diagnosis in ankylosing spondylitis. Now, in order to diagnose ankylosing spondylitis, we have various methodologies. Now, one methodology is via performing laboratory tests. The lab tests which are performed are usually of HLA-B27 because we know that it increases in ankylosing spondylitis and it also becomes misfolded. We also know that there is increased in C-reactive protein because there is increased inflammation. Also, there is an increased expression of CD4 T cells and decreased expression of CD8 T cells. And if we talk about the ESR or erythrocyte sedimentation rate, now that increases because again it is a pro-inflammatory disease, and in any inflammatory disease erythrocyte sedimentation rate increases. Sometimes patient also present with mild anemia. Now this mild anemia is due to less absorption of iron in patients which also have ischemic bowel disease. We also sometimes get patients with vital capacity which is decreased. Even though the functional residual capacity remains the same, the vital capacity is extremely reduced. And it is reduced because there is less expansion of the rib cage during the course of the disease. Another thing is that there is an elevated alkaline phosphatase levels. Now, alkaline phosphatase is an enzyme which is found at two areas in our body primarily. One, it is found at the biliary system in our body, and secondly, it is found inside the bones. So, whenever there is an inflammation of either the biliary system, like in cholelithiasis or choledocholithiasis, there is an increased amount of ALP or alkaline phosphatase. An example would be an obstructive jaundice. Another point which is in relation to the ankylosing spondylitis is that it is increased due to the increased osteoclastic activity. Now this increased osteoclastic activity is due to the osteoporosis which happens in conjunction to the inflammation of the joints along with their ossification. So because of this ossification and osteoporosis and increased osteoblastic and osteoclastic activity, we get increased levels of alkaline phosphatase. Then we also have increased serum IgA levels. Now IgA levels are increased because we do not know what is the exact incitatory event for ankylosing spondylitis. We know that it is pro-inflammatory. It has some kind of an autoimmune component too, but we do not know that what that autoimmune component is. But the evidence for the autoimmune component comes from the increased level of the serum IgA. Next, there is no change in the functional residual capacity, even though the vital capacity of the patient is severely compromised or decreased. Next, there is increased expression and circulation of the MMP3 or the matrix metalloproteinase 3. Now this enzyme is increased in blood. Now this is an enzyme which is usually found in the matrix, in the connective tissue and inside the cells. Now because of the all of the osteoporosis, the osteoclastic and osteoblastic activity, this enzyme spills into the blood and we get elevated blood levels of this particular enzyme. Next, the investigation of the synovial fluid. Synovial fluid of a patient with ankylosing spondylitis through arthrocentesis, that is the process by which we take a sample of the synovial fluid, is usually non-specific. It does not give us any kind of indication that the patient is suffering from ankylosing spondylitis. But we do get this confirmation that the patient is suffering from high levels of inflammation. So arthrocentesis is usually not performed because it does not have that much of a diagnostic capability. Next, we're going to talk about the radiographic findings. Like I said, in order to diagnose ankylosing spondylitis, we have to look at various modalities. One of those is radiology. And in radiology, we not only use the normal x-rays, but we also use other modalities of radiology too. Now, these modalities can be plain radiographs, and on plain radiographs, what we see is a vertebral column with its vertebral bodies fused together all the way from the cranium to the caudal area. Now, this is characteristic of ankylosing spondylitis and is termed as bamboo spine. Because if you look at on a normal X-ray or a normal radiograph, it looks like a bamboo stick. And this presentation can easily be seen at this one, that the patient is suffering from bamboo spine with characteristic bamboo shaped vertebral bodies. Another modality that we use is MRI. MRI is very frequently used because of the inflammation. Now, because the joints, either axial or peripheral, have inflammation in huge amounts or in huge severity, we have to employ a modality which can give us the exact amount of the obliteration or the disappearance of the tissue, even with the presence of that much amount of edema. So in order to do that, we have to employ the magnetic resonance imaging, because MRI is one technique which can give us the exact condition of all the organs and structures, even in the presence of edema or water at that area. Next, we can also employ a CT scan or a computerized tomography. Now, this scan is usually performed in order to find out if there is any other supplementary inflammatory areas or supplementary peripheral areas, and it is usually done via a contrast enhanced study. Next is the DEXA scan or the dual energy X-ray absorptiometry. Now, this scan is used specifically to study the osteoporosis of bone or the state of the mineralization of bones. So, this scan is usually employed in order to study patients who are female. One, because they are more prone to the osteoporosis during the inflammatory process, and it is also done in order to quantify how much osteoporosis has taken place at the localized inflammatory area. Next, now, these radiographic studies usually present themselves in a variety of manner. Now, for example, this is an MRI of a patient with sacroiliatis. Now, as you can easily see here, that this patient with sacroiliatis, which is unilateral because this area is normal and this joint is inflamed, and it is inflamed because we can see large amount of edema at this area. There is also inflammation of ligament, which is this thick arrow, along with inflammation of this ligament tendon, which you can see here. So this small arrow signifying inflammation of the tendon, and the small arrow signifying inflammation of the ligament, along with marked edema at this state area, along with some edema at the opposite side, easily signifies the inflammation of this sacroiliac joint. And again, this is a unilateral finding. The other joint is normal, with normal tendon and ligaments, no edema and no spacing. Because as you can see, the spacing at this area has also increased. Next, as for the radiographic findings, we're going to study about the lumbar spine straightening. Now, this is again a very crucial finding and usually points straight to the ankylosing spondylitis. Now, before the bamboo spine takes place in patients, what happens is, like I said before, that syndesmophyte starts caudally and moves cranially. So usually what we get is pain at the caudal area along with the straightening of the lumbosacral area, which then moves cranially and then gives us the appearance of the whole of the bamboo spine. But first, we only have the straightening of the lumbosacral area, and this straightening of the lumbosacral area has all the complications of the bamboo spine, like it is more prone to fracture and it gives us more dull pain in patients, reduces their flexibility and their range of motion. Next, we're going to look at the bamboo spine. As I mentioned earlier, that the syndesmophyte or diffusion of the vertebra starts caudally, moves cranially. Initially, it gives the appearance of the straightening of the spine, and when whole of the vertebral column has been recruited and changed into one single syndesmophyte, it results in a characteristic X-ray finding known as the bamboo spine. Now, it is known as the bamboo spine because it looks like a bamboo stick. As you can easily see here, that the vertebral bodies of this patient has no space between these. They are heavily ossified, giving an impression of the sectioning which is usually found in the bamboo sticks or the bamboo trees. Next, we're going to talk about the diagnostic criteria for ankylosing spondylitis. Now, there are two diagnostic criteria for this disease. There is ASAS of 1984, that stands for the Association of Ankylosing Spondylitis of International Society of 1984. Now, this diagnostic criteria states that if the patient has back pain of about 3 months or more than 3 months with the age of onset of less than or almost equal to the 45 years of age, if the patient have these symptoms along with sacroiliitis on imaging plus one of these features. Now, one of these features may be the sacroiliitis that is on the imaging with active inflammation on MRI. Now, the important part is the active inflammation. It should not be chronic. or there might be some definitive radiographic sacroiliitis according to the modified criteria. Now, if one of these is present along with the sacroiliitis, we can definitely diagnose the patient as with ankylosing spondylitis. Or if the patient has HLA-B27 in his or her bloodstream, along with two or more than two of these spondyloarthritis features. Now, these features may be an inflammatory back pain, it can be an arthritis, it can be an ascites, it can be anterior uveitis, dactylitis, that is the inflammation of the fingers. It can be psoriasis, appearance of white fish-like scales on the fish. It can be Crohn's disease. It can be a good response to the NSAIDs therapy, that is the non-steroidal anti-inflammatory drugs. It can be the family history or the family history with the presence of P27, because as stated in epidemiology that patients with the family history are more prone to the ankylosing spondylitis. Because if we take the example of North American white males, 7% of those present with the HLA-B27. And even among the identical twins, the concordance is 65%. So if there is family history of B27, it is considered one of the features. So sacroiliitis on imaging plus one of the spondyloarthritis feature, or HLA-B27 in system with two or more than two of any spondyloarthritis feature, can give us the diagnostic criteria in order to diagnose the patient with ankylosing spondylitis. Now, like I said, that there are two diagnostic criteria. Now, the diagnostic criteria of 1984 was revised in 2009. Now, it was revised because the early onset or the juvenile spondyloarthritis cannot be detected on the previous diagnostic criteria. Now, the initial symptomology will remain the same. The patient must present with back pain of about 3 months or more than 3 months, and age of onset should be either 45 years or less than 45 years. Now, along with these diagnostic criteria, just like the previous one, if we have 4 or more than 4 of these features, we can easily diagnose the patient with ankylosing spondylitis. Now, these are if the age of the onset is before the age of 4, in the onset is insidious, that patient does not know that there is some kind of process is taking place inside the body, or the onset is sudden and usually seems like without cause. There's improvement with exercise. There is no improvement when patient rests. There's nocturnal pain, that patient wakes up during the sleep times, and the pain subsides after the patient either has a little exercise or walks a little. Next, we have morning stiffness that ranges more than 30 minutes in the morning. We have alternating buttock pain. Now, these symptoms, if 4 of these or more than 4 are present along with those 2 initial symptoms, then we can easily diagnose the patient with ankylosing spondylitis. There are some other less common symptoms that can be taken into consideration but are not considered part of the diagnostic criteria proper. Now, these less common symptoms are metabolic, infectious, or malignant. Metabolic can be due to any metabolic disease such as acidemia or alkalosis. Infectious can be due to any kind of infections like infectious spondylitis, or it can be malignant. That is, there's some kind of sarcoma that is taking place in the vertebral column. And another is that we have to rule out the presence of DISH or diffuse presence of spondyloarthritis elements in the patient. Now, this DISH must be eliminated in patients presenting with ankylosing spondylitis. Now, DISH is a disease which has a very characteristic feature on plain radiograph. Now, in ankylosing spondylitis, we get syndesmophytes, which can result in a bamboo spine, but in DISH, we get the ossification or the hardening of the ligaments of the vertebral column, resulting in their hardening, and this presents in a wave-like sign on the radiographs, and this must be differentiated from the ankylosing spondylitis.